Pregnant code blue inpatient on maternal care is extremely rare, but we need to know what to do and be efficient in this type of emergency. The first 4 to 5 minutes are the most important, and that will all occur before the ICU code team gets here. So we need to get really good at the first 4 to 5 minutes of any of our code blues on the unit, especially the pregnant code blue. So COVID is still playing a bit of a factor. So when would the code be considered protected? It would be when she has respiratory symptoms. As a precaution, we would wear our N95 gown, glove, mask, shield. Or if she has come in and we have swabbed her and she is positive for COVID, we would do a contact droplet plus resuscitation, keep the people in the room to a minimum, keep the door closed, not do an AGMP until everyone has their PPE, including N95. So the first responder who's in the room could start chest compressions with a simple mask, but then everybody else before they come in would don full PPE, including N95. And then ventilation and intubation of the patient, like just bagging with a Laerdal bag is considered an AGMP, as well as attempted intubation. So if you are responder 1 and you witness a code, you are going to try and rouse the patient with some painful stimuli like a sternal rub. She's not responding. You check for a pulse. There's no pulse. Your first action is to pull the code blue handle, flatten the head of the bed, and immediately start chest compressions. The step stools are in the room to facilitate that. Or if you were shorter, you could try 1 knee or 2 knees. You're going to push hard and fast at a rate of 100 to 120. If your patient is pregnant over 20 weeks, and we determine the gestation roughly by saying if the fundus of the uterus is at or about the level of the belly button, she is considered 20 weeks. Then chest compressions become a 2-person job, and the second responder would perform left uterine displacement. And then if you and that person were in the room alone for quite a while, you would switch those 2 roles about every 2 minutes. Both are exhausting, but especially if it were a COVID positive room, you might be waiting a little bit of time for more people to get in there. So left uterine displacement, you cannot just tip her. The pregnant uterus is interfering with maternal circulation. If there is a 20-week or more baby on board and it's laying on her abdominal aorta and inferior vena cava, then her blood will not circulate lower than her waist. And so you can grab the baby and pull him from the right to the left from the patient's left side, or you can go on the patient's right and push the baby to the left side. You have to pull or push and hold it. You cannot just use a wedge. So that's responder 1 and 2. If you are any of the subsequent responders, your job is to quickly assess what's being done and then perform the next step. Perform the thing that needs to be done. And so I'm going to give you a list of things that need to be done. They're not in any particular order, but if you see something on this list that needs to be done, you go ahead and do it. So I've called them responder 3, 4, 5, and 6, and however many responders there are. Somebody needs to dial 321 and get the code paged overhead. It needs to say adult code blue, maternal care center, 3rd floor, JPCH, and the room number if possible. And what that does is the ICU code team will hear that page and come running to help us. When we pull the code blue handle, that activates an overhead page, but just within JPCH. So we also need to get it paged in RUH. Somebody needs to go grab the crash cart. You need to know the location of the 3 crash carts on the unit and bring it relatively close to the head of the bed. It needs to be plugged in, and the defibrillator pad's cord needs to be able to reach the patient. We're going to attach the AED stickers. We're not going to interrupt chest compressions, and we are going to shock as soon as we are able. Other things that need to be done, remove the headboard because the RT and anesthesia need to get at the patient's head at the 12 o'clock position in order to manage the airway. You can pull the bed out from right up against the wall. And another thing that you could do is set out the RT's intubation supplies and put them close to the head of the bed. The defibrillator on our crash cart, if you keep this little door closed that's indicated by this arrow, this defibrillator will run exactly like an AED in the community. It will analyze the rhythm for us. It will say shock advised, shock not advised. And if a shock is advised, it will power up and we will be able to deliver a shock as long as you keep the door closed. Other things that need to be done, put the side rails down, remove clutter, decide if the family wants to stay and witness the code or if they would like to be moved to a private room. Try and note on the clock the time that we started coding her. Someone needs to start documenting, and then someone needs to cover for other nurses that are involved. So we're looking after all the other patients on the floor as well. So if she's pregnant more than 20 weeks, we need to be thinking about the C-section that we're going to do, because it is a life-saving procedure. If we remove the contents of the uterus, whether that baby is viable or non-viable, it will absolutely improve her odds of survival. If the baby is viable, we now are going to be running 2 full resuscitations, one on mom, one on baby. So we need to think about where are we going to resuscitate this newborn. If it's on prenatal, we need to go with the baby to another room that has a Panda, oxygen, and gas hookups. If it's on assessment, where would we resuscitate that baby? Ideally not 2 resuscitations in the same room, but if the Panda was set up and ready to go there, then if that's the quickest option, that is what we might do. If you happen to grab the recorder clipboard and start documenting some times, if you go to the back of that clipboard, you will notice stickers, and these stickers are meant to identify people in the room. So we all know who each other is on maternal care, but the ICU code team doesn't know who we are, and the people that are coming from PICU to help us don't know who we are. So if you happen to come across these stickers, find them, put them on the people you know. It just helps improve team communication, and it helps identify who is in charge of the code. Charge nurse is the leader in any emergency. She should not put her hands on the patient. She should stand back and direct traffic. Anesthesia is the code leader until the RUH ICU code team gets here. But the charge nurse is managing the room and directing traffic. So there is a checklist that the charge nurse can pull out and start checking off things. There is a separate clipboard that is labeled charge nurse, and it will have the clipboard. It will have the checklist on there. So you simply start going through the checklist and make sure that these things are being done, such as determining a safe location for the newborn and support people. So here's the checklist. Again, a reminder, the charge nurse in any type of emergency on the unit is the leader in the room. She's not managing the patient physically or surgically or obstetrically. She's managing the other people working around the room, so she should not be doing direct patient care. What are the roles of the other participants? The obstetrician and obstetrics resident would be responsible for performing the C-section. The obstetrical anesthesiologist is the code leader until the RUH ICU code team arrives. Once they do arrive, then they can have a discussion of who's going to be the leader from then on. And then anesthesia may go to manage the airway. Also, we'll talk about the people coming from PICU that might manage the airway as well. So there's a respiratory therapist coming to from PICU, and RT manages the airway. So that will absolutely be the RT's job. There is a PICU RN coming, and they could help with any task, chest compressions, uterine displacement, pushing epinephrine, defibrillating. What they are PALS trained. They're not ACLS trained, but they're PALS trained. So they will definitely be a help to us because they run more codes on PICU than we do. The resource nurse, labor or postpartum, can perform any task, but we've sort of assigned them to be the documenters. So grab the recorder checklist, grab the recorder clipboard, start writing things down, handing out stickers. Anything you write down is better than nothing. Support staff. So there are two OR attendants. One of them is going to bring the glide scope, which is the camera intubation piece of equipment. One of them is going to bring that to the room so we can use a camera to intubate the patient. The other ORA is going to stand at the silver elevators and wait for the RUH code team to get there, and then direct them to the site of the code. The unit assists. The unit assist on team 3 is going to stand by the stairway by team 3 and wait for the PICU team to come and take them to the scene of the code. All other unit assists are going to stand in the corners of the hallways and direct traffic. So it's very important for everyone, if you hear a maternal code blue paged overhead, listen carefully for the room number so then you can direct people if there are people running around trying to find the code, and pay attention to the 3100. 3100 is assessment, 3300 is prenatal, 3400 is SRMC. Pay attention to the first two numbers that they call of the room number. So the RUH code team is coming, and they are very experienced in dealing with codes. So once they get there, we should absolutely let them take over. Again, it is the family's right to stay and observe the code if they wish, or we can move them to another location. But there should definitely be a member of our team supporting the family, giving them updates and explaining the situation. So the primary nurse needs to stay around because they have the story of the patient, what was happening that led up to the code, what allergies does she have, what medical conditions does she have. So she's going to stay around and provide information to the code team, and then assist in any way possible once she's delivered her story, and stay present. Code blue record, there is a formal form that does need to be filled out at some point. It doesn't need to be filled out right now. If you just take any piece of paper, even a piece of paper towel, and start writing down times, we can go back and fill in this record retrospectively. It does have 2 pages. If you ever have some free time or you happen to find yourself checking a code cart, you can go over this form. Just tips for documenting. You want to be able to see the clock on the wall. You want to use the same clock every time. You want to say things like, it's been 2 minutes since we started chest compression, switch compressors. Or you could say things like, it's been however many minutes since we gave epinephrine. But you want to announce something that's helpful, so people don't have to crunch numbers in their head, like, it's now 14:45 and we started chest compressions at 14:32. So how long is that? You want to give them the amount of minutes that things have been happening. So if you click on this link, there is a simulated video of a code blue. If you want practice documenting on a code blue, you could just take a regular piece of paper or pull out a code blue record and fill it out and mark down times as you go. It will help you to know what are important times to note and what all needs to be done in a code. And once you go through the whole thing at about the 9-minute mark, it would be the end of your exercise. Obstetrical considerations. So if mom loses a pulse, we are more concerned at resuscitating and saving mom than we are baby. We know if mom is pulseless, we know the baby is not going to be okay. We don't need to worry about fetal monitoring until we bring mom back with a pulse. The monitors are distracting and they get in the way of the work that needs to be done. Perimortem cesarean delivery. Why do we perform a C-section on pregnant patients when they're actively coding? The reason is that it will dramatically improve mom's chance of living. So there's case reports in the literature that out of the 20 women that had code blue, once they delivered the contents of the uterus, 12 of them had a spontaneous return of their pulse. So it absolutely improves their outcomes. It is not going to worsen mom's outcomes. The situation cannot get any worse. We can only improve from here. And so the reason is that this fetus is laying on her abdominal aorta and her inferior vena cava, but it is also, the body is dedicating a good amount of blood supply and flow to the uterus. If we end that blood circulation to the uterus by delivering the baby, mom's body will have more resources to fight for her survival than if a baby was on board. So how is it done? We want to really note the time we started chest compressions, because we are going to actively try and code her and try and bring her back with a pulse for 4 minutes. At the 4-minute mark, if we have not brought her back with a pulse, we are going to start the C-section, and that is to deliver the fetus by 5 minutes, because if he is at an age of viability, we also want to try and save him as well as mom. And so in order to give baby that chance of survival, he needs to be delivered by 4 to 5 minute mark as well. If there's absolutely no chance of mom's survival, let's say like a motor vehicle accident where there's profound brain damage, you can deliver the baby before that. But the goal is to save both. We perform the C-section at the very location that she coded. We do not move her. The only thing you really need is a scalpel to get down to the uterus. If we moved her, it would waste time. But also keep in mind, we now need to resuscitate a newborn as well. So we need to be ready for that in about 60 seconds, because the C-section is going to be very quick, very efficient. It's only going to take about 60 seconds to deliver that baby, and then we need to resuscitate that baby. So our code cart is the same as every other code cart in the city, except we have an emergency C-section tray. One of the things you can do if you're standing by is grab the C-section tray and bring it relatively close to the abdomen so that the physician doesn't have to reach or wait to be handed supplies. They can just grab the supplies that are on the tray. And this is what the tray looks like. So you will see there is a disposable scalpel in there, and there is also sutures to close the uterus and sponges. So take those things off the top of the tray, hand the scalpel to the physician. The metal instruments we will need a little bit later on, and obviously the sutures we will need. So try and keep track of those. Don't set them somewhere and then somebody knocks them off the table or hides them with a drape. But really all they need is a disposable scalpel, which is right on top. Another reminder about the code cart, there is shelves on the side of the code cart, and that contains IV solution bags, IV tubing. There's also a pressure bag. Let's talk about some of the more common reasons on our unit that might lead to a code blue. There's risks with everything we do. So the first thing, and you know, it's not super common, but there is the risk of it happening, is local anesthetic systemic toxicity. So we do a lot of epidurals on our patients. And one of the risks of epidural is that the local anesthetic, so the lidocaine or ropivacaine, is accidentally injected into a blood vessel and it enters the bloodstream and it is lethal. Now, why does this happen during an epidural placement? Well, there are blood vessels in the epidural space. So if you've ever seen an epidural inserted, if blood is coming back in the tubing, that means we're in a blood vessel. We absolutely cannot use that epidural until we get out of that blood vessel. And so the greatest risk is at the time of the test dose. So that's why we're documenting the time of the test dose, and we're also watching very carefully for signs and symptoms that this test dose could have gone intravascular. It can also happen at any point during an infusion, but it's more common with the test dose. So the signs and symptoms: ringing in the ears, numbness and tingling around the lips or mouth, a funny taste like metal or pennies in the mouth, fullness or water droplet feeling in the ears. And then the other things that would follow might be agitation, bradycardia, hypotension, some people seize, all the way leading up to asystole or a ventricular arrhythmia and code blue. And this usually occurs within 1 minute of injection. So before the patient goes unresponsive, we want to ask her any of these very particular signs and symptoms that are not caused by anything else other than this condition. Did you have ringing in the ears? Did you have numbness or tingling around your mouth, or a funny taste like metal in your mouth? That is very helpful information for us to know, so then we know what to do about this situation. So the treatment for local anesthetic systemic toxicity is intralipid. Put it on an IV tubing, a pressure bag, give it wide open. This intralipid is stocked in every crash cart. And what this does is it binds to the lidocaine in the bloodstream and removes it from the bloodstream. Next, we have another incident that could lead to a code blue, and this is an accidental spinal injection. So when we are doing an epidural, we mean to infuse solution into the epidural space. But what if we accidentally go one level or one inner space further? That means we're in the spinal space, or what we call the intrathecal space. And if we inject an epidural dosage of medication into that spinal space, that will be way too much for her. She will get instantly numb. Her legs will feel heavy. Her bum will feel warm. She will instantly not be able to feel her legs. And then she may or may not go unresponsive, may or may not seize, may or may not go into a pulseless apneic situation. So the key things that we want to find out in this situation is, are your legs numb? Did your bum go immediately warm? Can you move your legs? Because if she answers yes to any of those things, then that tells us that it is an accidental spinal injection and not local anesthetic systemic toxicity. So it's very important, if these people go unresponsive, that we know which one it is, because the treatment is different for the two. So the treatment for LAST is intralipid. The treatment for an accidental spinal injection is to perform ACLS and send her to ICU, intubated and ventilated until the spinal wears off. One more thing to mention about these critical situations is that it is very important that we debrief and we perform self-care, so that we aren't traumatized by these things, that we can continue doing the work that we do. So there should be an immediate debrief, but then also there should be activation of our CISM team. Maybe there's a later on emotional debrief, and also a tactical or a operational debrief. Keeping yourself healthy mentally is also very important, in addition to the nursing work that we do for our patients.